Thank you for the introduction and good afternoon, everyone. Thank you for staying until my presentation, which is the last of the day. Today we're going to see how technology, for example, robots, IoT, or other things like AI can help in infection prevention and control. Just a slide about me. I'm an assistant professor in biomedical engineering at the University of Warwick. I have international collaborations with IAMBES. I'm Secretary General for IAMBES, which is the European Alliance of Medical and Biological Engineering in Science. And I have collaborations with the IFMB, which is the International Federation for Medical and Biological Engineering. My main research interests are actually medical device design and regulations, in particular for frugal innovation, so for designing medical devices resilient to the challenges of low resource settings. But I also do work, I've done some work with, in bioethics and infection prevention and control and preparedness. Preparedness is a word that I'm sure all of you have heard a lot in the past 4 or 5 years. This is has become more and more something that we heard of because of COVID-19, because COVID caught us unprepared. And in the next few slides, we will see what it means to be caught unprepared. But why is it important to speak about it now? It's because the next pandemics are inevitable, and this is not me saying that, but it's many experts in the field. This is due to climate change and global warming and the possibility of, the more and more possibility of having zoonosis, so the transfer of disease from the animal to the human. So this can be a potential cause of pandemic. I think that there were a few talks today about that I saw in the program. Oh, these are my old slides, doesn't matter. But I will just go to here. So this is one of the first things that happened when COVID hit. There was a surge in the demand of personal protective equipment. This was the first line of protection that we had. Because if I actually go back to this slide that I had deleted, this is the type of actions that one can do to protect oneself. And at the bottom, so at the tip actually of the pyramid, there is the PPE, which is the least effective one. This is once we are exposed to the issue, we can only protect ourselves with respirators, face shields, and stuff like that. While other things that are more effective, but that at the beginning we couldn't really be doing, are the elimination, which is the vaccine. I think it was written there, but the vaccine, as we know, came, I think, 1 year later after COVID hit, and also it wasn't a sterilizing vaccine, so a vaccine that would eradicate completely the problem because they were not 100% effective. So what we had was a surge in this demand of PPE, and the problem is that the manufacturers back then couldn't meet the increased demand. And although there were other manufacturers that were happy to convert their production line to produce more PPE, this was not, at the beginning there was a big bottleneck that I will show in the next slide. But before I go to the next slide, these are a few headlines from the news, and perhaps the most peculiar one is the last one, where the NHS workers had to wear bean bags as protection because they had nothing else. So this is something that in the biomedical engineering, especially in the medical device field, we would call the off-label use of something, when we use something that is destined to something else for another use. This is the reason why the manufacturers couldn't convert right away their production, because of standards. Standards are there to protect ourselves, of course, and to make sure that things are done according to guidelines. But the standards existing for personal protective equipment, for example, visors, face shields, respirators, were too strict and too generic, because these kind of devices could be used not only in healthcare, but also in industries which are much more dangerous in other aspects, like heavy metal industry. And there were some kind of tests, like a myriad of tests that these devices had to go through, including bullet tests for face shields, which may be in the healthcare healthcare setting for COVID protection is not really important. and respirators had to pass the heat test to 75 degrees again. So this situation unlocked only when the standards associations had published a subset of relevant standards only for COVID-19 prevention. Another thing that, another keyword of the pandemic was responsibility. Often there should have been more responsible thinking, responsible action, and responsible silence, because from one day to the other, everyone turned into an expert. Our neighbor could have turned from a lay user to a doctor with 20 years of experience, or an engineer with 20 years of experience, suggesting to the other neighbor to do this or that. Most of the times, these were useless, so not really protecting the user, and sometimes there were even dangerous suggestions. This was not only limited to the lay users, but also government had made many mistakes. For example, there were orders of the wrong kind of ventilators here in the UK, but also in France. You can see here some of the headlines where imagine the waste of money behind that. And finally, the other big keyword is infodemic, so the pandemic of information. You might recognize some of the most diffused false information during COVID. Drinking bleach can cure COVID. COVID can be spread through 5G network, or the vaccine has microchip that is going to, command us. So these are things that, because of the more and more interconnected world we live in, are actually dangerous right now, because if they fall in the wrong hand of an uninformed user, it can lead to a big problem, as we have seen it happening. So this is what set the basis for one of the works that I'm presenting today, which is on the best and worst practices during COVID-19. This was a systematic review that was performed as an interdisciplinary work between biomedical engineers, bioethicists, policymakers, and global sustainable development experts. The goal was to understand what were the main points of the main best and worst practices that were during COVID. Why is it important to do that? Because we need to learn from our mistakes and plan ahead for the next pandemic. So without giving you details on the method, I will just skip to the results. One of the things that is to be highlighted is that there has to be increased communication between policymakers, scientists, that are those that make the research, and the public, and also the media, that sometimes the way they convey the messages is not really very close to the truth. It depends what kind of media. We also noticed that local, contextualized interventions were better and more successful, more efficient than those one-size-fits-all kind of solution. And we also, of course, one recommendation is that there should be a more alignment between local healthcare system and the hospitals and the public health system. The other thing I want to point out is the innovation technology, which then links me to the other part of the talk, which is that we could have leverage, or we could leverage more digital health, not only for the screening and the treatment of patients remotely in case we have more and more requests and the hospitals are overburdened with this, but also in cases if there is we cannot really get close to the patient because there's, for example, COVID-19 or another kind of pandemic. But this is also true for infection prevention and control. So there can be latest technologies that could be used in order to improve the way we manage things. And this is the other part of the talk, which is about another review that was performed in terms of, for looking at the smart environments and robots that were used during the pandemic to perform infection prevention and control. What we found is that there were 5 main areas. One was hand hygiene compliance, which the previous speaker has already surfaced as an issue, even non in pandemic times. We had automatic infection cluster detection and environmental cleaning technologies. These are the three main explored ones, but there were other two that we will see in a few slides. So how did we go on about this? We selected OVID-SP as the main database. We had a search string that we developed looking at relevant keywords of the field, looking at literature and speaking with experts. We then followed the PRISMA statement, which is a standard for performing systematic reviews. We screened them through title, abstract, and full text screening. And we extracted the relevant data in a table that I will show you in a bit. We also performed quality appraisal, because this is one key step for systematic review to understand the quality of the information that we are collating into the paper. Since the studies were of different type, we used this tool, which is called MMAT, Mixed Methods Appraisal Tool. And then we, as I said, we grouped the results into 5 areas. I mentioned 3 before. The other 2 that I didn't mention were air quality control and correct use of PPE. So for example, you can see in the blue box that for hand hygiene compliance, there were wearable sensors or RFID tags being used. Infection cluster detection, there were AI methods being used. For environmental cleaning, there were, for example, cleaning robots. Air quality control, again, AI algorithms to control the quality of air. And again, AI used for understanding whether PPE was being worn correctly. So we started with 1,520 papers that then, through the process that is highlighted on the left, we got them down to 17 based on the inclusion and exclusion criteria that we had identified. And this is, I don't think you can read this small font, but you can, if you're interested, you can find it in the paper. And there are 2 slides with more in-depth example, but what we were extracting were the area of the topic. For example, for the third one was hand hygiene compliance. The device for infection prevention and control, in this case, was hand hygiene compliance system. The aim of the study, in that case, was to evaluate the device impact on the healthcare-associated infection rates. The participants, so it was tested on staff and also on patients, and the department where this was tested. In this case, was the whole hospital. To go a bit more into detail, this one by Wang et al. Was a study on hand hygiene compliance, the title being 3-year hand hygiene monitoring and the impact of real-time reminders on compliance. What they were using were RFID tags to monitor every time a healthcare worker was gonna perform hand hygiene before and after visiting a patient. As we saw, it is a problem still nowadays. This was tested on more than 100 patients, healthcare workers, and on more than 500,000 activities observed. What was it observed? That across these years, you can see on the left, there is a sharp increase in the number of hand hygiene compliance, hand hygiene events. The blue line represents only the use of RFID tag to monitor whether the person would perform this, and the red one is with reminders. So one point of this study is also that using reminders, but in a random way to avoid the development of users' fatigue and to avoid that, when you have a constant beeping, you start ignoring it, can be also a solution to boost even more the rates of hand hygiene compliance. This one was a study by Khan et al. That looked at the types of robots that were used during COVID-19. There were different types, for example, the nurse robot, the ambulance, the serving robot, and disinfecting robot. And what they found, among other things, is that there was a significant reduction in hospital-acquired infections when the cleaning of the environment of the hospital was performed by a cleaning robot. So also this has a potential impact The conclusion for this part is that another thing that we notice in these studies is that most of the practices of IPC in hospitals nowadays are still traditional and paper-based. There is not much technology being used at the moment. It's mainly research-wise. What we also found is that the healthcare workers are not trained to use these potential technologies, and most importantly, they are not involved in the co-design of these technologies, which is vital for a technology to be effective and efficient. Also, one other thing that has been, like in the medical device field, so far not really much regarded, is the fact that these solutions need to be tailored to the context, in particular if we want to go into low and middle income countries type of context. What is happening meanwhile in Europe? These are the last few slides. This is a project that has finished this month, and my lab was part of this project, although I was not the mainly involved person in this, but I'm going to report. ODIN is a European funded project that was aiming to create a platform that would interconnect possible use cases in terms of robots use, smart environments, IoT, and AI to increase the safety and performance of hospitals. This is the consortium, so it's quite big. I don't know exactly how many, but it's a mix of universities. Warwick is one, University Campus Biomedico in Italy, Università Politecnica di Madrid. We have also companies, Medtronic, Philips, and other ones. We had 6 pilots across Europe, 1 in Italy, 2 in Spain, 1 in Poland, 1 in the Netherlands, and 1 in Germany, all looking at different reference use cases. And, well, the aim, I spoke about this aim, but the important bit is also that it was a co-creation. As I said, this word I mentioned before is a quite important keyword in nowadays design. And also not only to demonstrate the effectiveness that AI tools and robots and smart environments could have into increasing the safety of patients and healthcare workers and the performance of the hospital, but also to contribute to increasing the trust into these new technologies and AI, which we know that this is also a very important point, because if we don't have trust, the uptake of these technologies will be quite low. These are just some, in the new slides I can tell you what there was. There were some videos of the reference use cases. So one of them was a system that via cameras would recognize the amount of people in a room and the activity that these people were doing, standing, walking. So this could be used in terms of IPC to see whether, in a room we have a maximum number of occupancy, or we need a certain amount of distance between people. Another case was about a serving robot. So you can see a nurse that needs to deliver something to another department. They put it in the robot, they select the destination, and the robot goes to the other department by itself. Or a doctor robot, a doctor AI, which is instructing the parameters and the procedures that paramedics need to perform on a patient. It was another case. And finally, there was, I don't know if you know, the Boston Dynamic dog robots, also that they are using, could be used for IPC purposes, because you could use it to go to different rooms and take swabs of, let's say, the keyboard of an ultrasound machine or the surgical bed and stuff, and control. And in that way, you can monitor pathogens without going there by yourself. These are just a few readings. There are other that I had added, but doesn't matter. That are the outcomes of this ODIN project. And this was my last slide. Thank you.